I think I've admitted everyone who was in the waiting room.
All right, so we should just start then.
Go ahead.
Okay. Hi, everyone. My name is Deborah Young, and I just want you to know I really value your time. So we're going to go through the presentation and then come together. And that's when I'll ask you to turn videos on so that we can actually talk about this, ask questions, and have a conversation. So I hope that works for everybody. If you use your hands and thumbs up, that's always helpful. So I know that people are there. Hi, thanks for turning on your video. All right, so my name is Deborah Young, and I have an organization called Empowering Communities Globally, and it's actually been around since 1997. We work in refugee camps and natural disasters and conflict areas around the world. My background is early childhood education, leadership, policy, and administration. And so I have a PhD in each of those. However, most of the reason why I got those PhDs is because of representation at the table when policies are being made. Very rarely are early childhood people invited, and very rarely are voices of refugees and immigrants at the table either. When I attend the table, I am always bringing the people who have the lived experience at the table with me. Excuse me for my voice. I woke up this morning and it was gone. So sorry about that. So this whole presentation is about supporting refugee and immigrant families, specifically moms, maternal health, but the family, we can't look at maternal health without looking at the whole family situation as well, and mobilizing community support stakeholders and structures. So right before COVID started, I left the university and started to do the work I did around the world here in Colorado. And to my surprise, we have more gaps and barriers systemically in Colorado than they do in refugee camps. I was astonished. I could not believe the systemic bias and barriers that existed in the home country. This model is something that we use, and I'm going to go over each of these steps because they're critical. It was informed by over 300 women in 8 different countries. And that's how we came up with this model. So it is culturally responsive, adaptive, and it works from rural areas all the way where we work in landfills. So we do work in the landfills in capital cities because a lot of landfills have populations that actually live on the landfill. And there are families and moms giving birth and raising children. And so we do have a wide experience. And so we're going to go through each one of these and talk about what does it really mean? Because when we look at this, it's like, okay, well, this makes sense, but what does it really mean? So I wanted to also talk about first some of our pillars. So again, we can have this, and this is a process, right? However, this is our values. These are the values that we hold and share. Cultural humility. We all have implicit bias. I am there to learn and share. Everyone brings an immense intelligence to the table. Their lived experience is more relevant than my PhD. And so understanding that is really, really important. Being in the academic world, I have met so many times people going and studying on people, not studying with people. The cultural humility is, I have access, I have privilege, I can write this down, I can get your voice out, I can do things that you cannot do, but I can't do it without you. You are really the lead. And so on any publications we have, we always put the people who work with us from the community as the first authors, because they truly are. Their lived experience counts. So this is a lifelong process of self-reflection and self-critique. That's what cultural humility is really about. It starts with an examination of our own beliefs and her cultural identities. It is the practice of cultural humility in our every single day actions, everyday actions, to be aware of one's own own values and beliefs. I was just in a training last week, and one of the trainers said to one of the women, and she was a refugee, she said, "I don't know how to pronounce your name. Can you tell it to me before I butcher it?" I mean, what a way to ask somebody, how do you say your name? And this is right, the 21st century. This happened last week. And I had to say something, because if I didn't, then I am condoning that behavior and part of the problem. So how do we become not advocates or allies, but truly accomplices? Because if we want refugee and immigrant maternal health to be attended to, we have to break and counter systemic bias as well as lived bias every day. And I have, I honor the privilege and honor I've had working with women who really push on me and hold me to it. But that took a lot of trust building and relationship building. The next one is do no harm, right? Go slowly. We want change in this world so quickly, but in reality, it's relationships that count, and do no harm. Don't go forward until we're sure. Because if we do harm, we can actually counter 2 years of work with one piece of harm. So it's really, really important. The equity inclusion, being a white woman from the US, I need to be listening. I need to know what equity inclusion really looks like for a refugee and immigrant. I can't think that I know it. So it's really those involved conversations and having them lead the discussion and the needs that they have. We use a participatory action research framework in everything we do. I don't know how many of you are actually familiar with it. However, it is not community-based, it is community-led. So all the design, the decision-making, how we monitor and evaluate is decided and led by the community who the research is studying. So what happens is that every single step of the research, the community is learning. That means their capacity is building. So when I step away, they can do all of this on their own. And they're leading how we do it. I cannot tell, well, I could tell you because I'm going to, but so much of our monitoring and evaluation and our research collected is dominant, right? It's mostly highly educated male forms that have been created to collect data. That right there has a bias. If we don't listen to how to collect the data, how to analyze it, what it really means, we're going to be missing some amazing pieces of information to truly make change or transformation. We want to make sure we always come from strength-based and asset-based. How many times do I hear, oh, the poor woman, oh my gosh, they've gone through so much. And all that may be true, but think of the resilience. How did they even get to the US? That process is horrendous. And how many of us would survive so well? So how do we think of what the assets are? Like, for instance, one woman from the Republic of the Congo I'm working with, how she, her story, her 3 different refugee camps, and how she taught herself English to become an interpreter so she could get on the list to become a refugee in the US, right? I mean, the intricacies and the networking of that. And she was learning that from 6 years old. Right? So the strengths and the assets they bring are so incredible. All we have to do is look through a strength-based lens. Again, relationships are key. And part of the cultural humility is to fail forward. Don't think we're not going to fail. Well, I call them cultural bumps. You can't imagine in 35 years how many cultural bumps I've had. And boy, there were times I was so embarrassed. My face would be bright red. And the women would just open their hands and heart and chuckle with me and say, it's okay, we'll help guide you, right? I'm the one who needed the help guiding. I had to fail forward. And then together as a group, as we build, we also allowed fail forward. So many of the women that I work with who are refugees in this country are so afraid of failure, because if they fail, that's like the one opportunity and then they're gone. And so to really create that space of safeness, that we don't know what we're doing, because if we did, we wouldn't even be in this situation, right? And so how do we look at our failures as the tremendous opportunity to learn? And most of us on this call understand this, but to practice it is different than just understanding. So the first step is that community, building trusting relationships and available resources. Well, if we're talking with refugees and immigrants, if we want resources available, we have to talk about language justice, right? It's about, and it's not just about the diversity is who is at the table, but who is not at the table. So many times we go, oh, well, we have this and this person from these places. Great, but who's not at the table, right? And why are they not at the table? And how do we go out and build that trust? So I'm going to give you just one example that we've been working with in Colorado for the last 2 years. We got a grant to build FFNs, at least in our state. 60% of childcare, which is a lot to do with maternal health, is done in FFNs, family, friends, and neighborhoods. 40% is provided through licensed home care or child care center programs. And guess what? Of course, we know that those licensed centers are not located in communities of low income or impacted by poverty. They're usually located in places where people have transportation, they can afford the center. I mean, we can go on in those lists. So FFNs are really used in the communities that we're looking at. And they're afraid. They're even afraid to tell us they watch other people's children because they're afraid the state might do something. So it took us 8 months of just building relationship with a core of 4 women from 4 different communities, refugee communities, to build enough that we even knew some of the people who are doing FFNs. And those were the brave women who said, okay, I like you, so I'm going to just give you a little bit of a chance, but and so it took us 1.5 years to build the capacity, where now 2 weeks ago, we have 6 people reaching out to us to build their FFN, their own entrepreneurship in their home. So it's not quick work. Some of the refugee camps, refugee camps now are usually, people don't leave them for 20 to 25 years. So they're not these temporary places they were 35 years ago, where 3 or 4 years. So we have generations happening in the refugee camps, as well as on the landfill and other places. So it's a long-term relationship. Most of the places that I work with around the world, I've worked anywhere between 12 and 35 years. It's an ongoing relationship. You don't ever really leave it. So I think that's an important piece to know, that these trusting relationships are, lifelong. And that's why I'm in this work, is because I feel like I'm the richest woman, because I have so many amazing relationships. We got to fight because they can get workshops, so many workshops, right? This person's willing to come in, that person's willing to come in. But what about certifications? And who are teaching those workshops? Many people who teach the workshops look like me, right? And so how do we get workshop trainers to look like them and speak their language, right? Without language justice, they don't even have access to some of the information. So how do we finance that? How do we make sure they're culturally responsive? We can use interpretation. We can use some translation. Hardly does anyone ever put that in their grants. So rarely is it used unless it's intake or there's a medical problem. But it's not just widely used as part of a system. The other thing is community-based doulas. Right? We're just in this country, at least in our state, are really recognizing the importance of doulas. We know that at risk the cesarean section, 25 to 39%, increased likelihood of spontaneous vaginal birth by 15%. We know that it reduces the use of pain medication in labor by 10%. Their labor is shortened by 40 minutes. Excuse me, and it reduces the likelihood of a low 5-minute APGAR score by 38%. So we know doulas are important. We're working with the Afghan newcomers. We have 2,000 to 3,000 new Afghan newcomers. 2 of them gave birth in the last 2 weeks. They're from Afghanistan. They're Muslim. They speak Dari. One spoke Pashto. So here they are in the hospital giving birth with a male on the computer interpreting what the doctors and nurses are saying. And you can imagine they've never been in a US hospital before. And this is supposed to be the most beautiful time in your life, giving birth. So we now have our first certified Afghan doula. And it is one of those programs that we're going to be continuing working with to expand, is because somebody to accompany you who shares historical context, who speaks the language, who can relate, right? It's just amazing how different that is for the mother's maternal health. She doesn't have to be in fear and anxiety while she's trying to go through labor and push. And that's just the beginning. Who visits afterwards to make sure that the milk is coming in and that the connections, some lactation specialist who probably looks like me and doesn't speak the language. And then I go get an interpreter. But do I know that if you live in Morocco, I should probably not get an Iraqi interpreter? I mean, there are tensions in the world doesn't mean they go away when refugees come here. So how are we really going to be literate about this kind of thing? So some of the barriers in the real world to create that community, relationships, key to life, key to everything. Language, we need to have language justice. Everyone has a right to express themselves in their heart language. If I'm going to express to you what's going on in my body during labor, or what's going on in my body when my child is melting down and it has these behaviors I've never even seen or heard of, I have to be able to express it in my heart language. Trying to say it in a second or third or fourth language, I can't really communicate very well. We need to understand historical contextual experiences. And I've already asked permission to use this story. She's 6 years old. She's from the Congo. And they're agriculture and they work on the farm. And that's how she was learning life, is working on the farm. And then people who escaped Rwanda were coming and taking all their food from their farms. And when they ran out of food, then they started coming and killing everybody in their community. So they had to run to the refugee camp. Now, as they're fleeing to the refugee camp, she's seeing horrors that are happening to women that she knows beside her. Those historical contexts shape who I am as a woman, who I am as a mother, who I am as I grow. Those historical contexts influence our behavior. Many times I've been in conversation where they're like, I just can't get through to them. They won't let me in their door, like an OT or somebody trying to get into working with a refugee family, but without understanding what that is. She seems so distant from her children. Well, if all the children die around you, why would you become attached to your child when the chances of them dying is much more high than low? You have to teach them everything they need to survive. But if you become too attached, you're going to die from the heartache. Right? So historical contextual experiences are key to understand working with refugee and immigrant moms. That's why we need to get people who look like them and talk like them in professional areas to be able to work within their own community. There are cultural nuances. I work in Central and South America, and I could not put the cultural nuances in Nicaragua as in Ecuador. I would be totally off off base, right? So we have to learn these nuances. I don't know about you, but the only way I can learn them is by asking people who live there. Otherwise, how do I know them? And one of the most important is to recognize our power dynamics. I usually have the power, right? And so how do we share that? And yes, that's our job, to share and make sure that that mom who we're working with in front of us feels powerful, that we are sharing that power. And all these photos I'm using are from people in our ECG group. So what happens, even prior to the stressors of the pandemic? A significant portion of pregnant and postpartum people in Colorado reported experiencing anxiety or depression, and many of them struggled to access the care and support they need to feel better. And that's before the pandemic. The new challenges many parents experienced during the pandemic: more social isolation. So here you are coming to the US, your sister might have gone to Australia, your brother to Germany, you're totally socially isolated in a world, but your kids were still going to school. You might have gone out and talked to some people, but then the pandemic, right? So can you imagine the difficulty accessing healthcare, the economic hardship? They likely have been exacerbated, as well as mental health struggles. So let's just pause for 10 seconds and think of the implications for parents and caregivers who are refugees and immigrants, and how those are compounded. And although the infant mortality rate has fallen in Colorado and across the US during the past decade, maternal mortality has been increasingly common. In 2019, the maternal mortality rate in the US was 20.1 deaths per 100,000 live births, up from 17.4 the year prior. As in the case for many other health outcomes, unjust and inequitable policies, practices, and systems that burden mothers of color, mothers who do not speak dominant languages and have dominant patterns of behavior. This has created racial and ethnic disparities in maternal mortality rates. In 2019, the rate for Black women in the US was nearly 2.5 times higher than the rate for non-Hispanic white women. And put refugees on top of that, which most statistics do not even desegregate. So there's a systemic bias right there. So a recent report from the Colorado Department of Public Health and Environment examined pregnancy-associated deaths that happened during pregnancy up to 365 days postpartum that year, and those that occurred in Colorado between 2014 and 2016. And the data included in the report to point to an urgent need for better support for Coloradans who are pregnant and postpartum mental and behavioral health support. That is what is critical. Suicide was the most common cause of maternal death between those years. Some of them were it was followed by the next unintentional drug overdoses, prescription drugs. That's an ouch. So the next one is just here. We have to have wraparound services. When we're doing maternal health, it's all about wraparound services, ESL classes, professional development taught in their first language, mentors to support them, childcare. They can't even come to the workshops if you don't have childcare. Coaching in the home through home visitors from people in their community, check-ins, sometimes daily, sometimes weekly, eventually maybe monthly. Individual and group needs. This is a community, not just a family. And we have to align with cultural values and beliefs. And those are the Jedi practices. So you have access to this. So I'm not going to go through every one of these, but these are the general recommendations. The overarching piece: create a sense of belonging. Have them feel like they belong to some community. Most refugees and immigrants are isolated and have very little sense of belonging. We start with initial conversations about barriers, right? And I don't use the word, what are the systemic barriers you have encountered? I'll say, what are the complaints you have? Because in every single complaint is a value. I can't get to my hospital. I can't get to my health clinics. I don't have transportation. I don't have childcare. What am I going to do? That complaint says health is really important for you. That's that asset and strength-based, right? So when I hear their complaints, I have to find that value. And wow, you really do value taking care of yourself and your family, right? When somebody complains and you say that back to them, it can open their heart and it can just calm them. Like, you saw me, you heard me, you know what I'm trying to do. It's not about just fixing the transportation and fixing it. It's about seeing that that woman in front of me cares and she cares about her family. If they want to go to school, oh my gosh, that's a whole nother level of systemic barriers that we talked about. Interpretation, navigators. We need lots of navigators from the community who understand how to get people through systems. And we only use a cohort model. So we have a minimum of 4 moms in every group we have, because they also have to have that community building, the trust retention, completion, all increases if you have a cohort, people who look, talk, and have a shared historical context. Trainers, instructors, everyone's got to get on this language justice wagon, right? We really have to use heart languages when we're talking maternal health. How can they express themselves or even hear what's accessible to them if we can't even commute with language? So birth is more dangerous for moms who are Black, for moms who are refugees and immigrants, for moms who are Muslims, for moms who are people of any color, right? And that is so, so important. She is also one of our wonderful people in our group, and she is becoming a doula and a lactation specialist for her community. At the moment, she is a child care provider. 2 years ago, she knew nobody. She was in a state of depression. She was in an abusive situation. And we just surrounded her with people in her community and said, well, we believe in you. What do you want to do? What do you want to be? She almost has her associate's degree. She's, half the people in her cohort have never been to formal schooling. They don't have high school degrees because they couldn't. You go to a UN school, I mean, it's like in 3 different camps. How are you going to get a high school diploma? But that shouldn't be a barrier to go to college. A US high school diploma should not be a barrier for women to go to college. And she's doing it. And she describes it as, I was a bird in a cage and I had a sheet over me. First, the sheet got uncovered and now the door's open. And those were her words. So Jedi principles, I can't push on them enough. Cultural training to unpack our implicit biases. Of course, we're all raised with bias. I mean, how can we not be? We're human and we're raised in a cultural specific context. Are we aware of them? Are we aware, like the woman who thought she was being kind by asking how to pronounce your name so I don't butcher it, right? There's definitely a better way of saying, how do you pronounce your name? And not just pick her out of the bunch, right? She's already picked out of the bunch because she doesn't look like anyone else. So how about we say, I would like everyone to say their name clearly and introduce yourself. That way she's got a chance to say her name just like everybody else, rather than, hey, you over there who looks different, how do you say your name? That's basically what we're doing. So we got to think about that. We want them to be advocates for themselves and we want them to be emergent leaders, right? It's not about us advocating for them. I was sitting, so one of the things we do is we have moms in our program and we go through advocacy training. And then we start bringing them to all these state committee meetings. And we never let them go on their own first because they want support and confidence. And one of the women I first started with, she was ready to go and speak. So here I am next to her. We have our computers open because she's so nervous. She's like, I'm afraid I'm going to forget what to say. So we're texting through messages, right, on our computers. So if she gets stuck, I can help her through that. So here she is sharing at a state committee meeting. And the person running it said, we need professionals here to give their opinion. That's what she said when this refugee spoke up. And all the practice, 4 months of practice for her to get to that committee meeting. And she was an attorney in Afghanistan, right? And so that's what the lead said. We need professionals to speak here. And so that's where the accomplice comes in. I said, I am so glad that you said that. How many of you have a PhD in refugee and immigrant? Well, we have one right here. She has the PhD. She is the expert. Why don't we use her? But those are the kind of emergent leader and advocacy people. Those are the barriers and the blocks they constantly run up. And we do have to be accomplices. We cannot just sit by and let that happen. We have to counter the systemic bias. So let's see. I just want to give we're going to go through that question in a minute, but more push on the languages. If you talk to a person in a language they understand, that goes to their head. If you talk to them in their own language, that goes to their heart. So that's why we call it heart languages. They get to say what their heart language is. So we go back to, I think, whoopsie, I'm not sure what I did. But I'm just curious, what struck you as new or surprising, and what would you like to know more about? I spent a lot of time on the community building of that 5-step model, the education, the participation, and then I did talk about a little bit about the empowering and how people are being transformed, right? They believe in themselves. So please speak up, ask some questions. I'm hoping that this will be much more participatory and interactive than me just talking at you. And if
I don't know if you were able to see any of the comments that some people commented on the line, the poor woman is a line that's applied when people apply their own values and assume a woman is being oppressed or living a life she does not choose to live. So I think that's just a really good insight.
Yeah, and I had no idea. The first grant we wrote was in 2019. We met with a group of refugee. And so the state was doing, how this all started is the state was doing an early childhood needs assessment for our preschool development grant. And the person who was leading it, I said, oh, so how many refugee and immigrant voices do you have? And she went to tell me, well, you can access the survey online. It's in Spanish and English. And I said, so you're telling me none? And she looked at me and I said, if it's online, you have no refugee and immigrants. You know, and so within 10 days, because they only had 10 days left, we had 4 focus groups. And we had about 12 to 18 women and fathers in the focus groups to talk about early childhood and their position. It was the first time the state ever had refugee and immigrants, non-Spanish speaking, in their surveys. From there, we took those focus groups and we had listening sessions and then individual interviews. And that's how we built our program out. We were going to take 30 for the first year. We ended up with 92. We never advertised. It was only through word of mouth through those focus groups. 92 women who entered the program. Now we have over 120. And this was the first semester was 2020. So it's been in 2 years. We have a waiting list of over 85 women. And we haven't even started to market. So obviously it's need.
That's exciting.
I'm calling in from Southern California, and our region is one of the areas that's received a lot of refugees recently. So I'm blown away by this presentation. There's so much in here that's just so beautiful, and the approach that you bring to it is just incredible, and no wonder communities are being reached. I just really love it. So I'm trying to work locally in our county to help bring a voice to these people, to help these refugees and their families become seen. And I think I think the struggle is, and you touched on it when you called it heart language. It's something I'm really taking in, but I think the struggle is this constant response. Well, services have always been offered in English and Spanish in our communities. And if people speak other languages, then they're, the programs will say, oh, well, we have translation service. And I don't know what the quality of it is. I heard it's extremely off. I mean, I've heard stories of what's being translated. And so I kind of get the sense that there's this comfort zone of working with English and Spanish speaking communities and opening the door to folks that they're just not used to working with, and needing to think about language and all of these other services. And I feel like there's just a fear on the part of and this might be me projecting, but I see this huge reluctance, and it's I guess it's been difficult for me to paint the picture of how this, not only, I mean, the need is understood, but how this is doable. And it just seems like this very big beast to try to, so I need support or advice on that of how do I make this?
Oh, I really appreciate that. And when I came into this, I had no idea either. I'm like, what do we need? How do we do this? One of the things is dollars has to be given to equipment. We have to have interpretation equipment, and we have to pay for simultaneous interpreters. So when we started this, it was like, okay, we could have somebody interpreting in the back of the room with all the women who speak Arabic or Farsi or Tingruana or Kinyarwanda, right? So we have all these different languages, but where are we putting them? In the back of the room. Why? Because their whispering is bothering those in the front of the room who can understand the dominant language. So we don't want to do that. That's separation. That's fragmentation. So what we decided to do is, who does it well? Well, I can only think of one organization, the UN, right? They do it well. People can have simultaneous conversations in many languages. How do they do it? So I wrote to the Highlander Institute. That's where Rosa Parks and Martin Luther King and Jr. and all those people went to learn how to organize. And they said, what do you do and how do you do this? And they also said, we're still learning, but this is the equipment we use and these are the successes. So I went and investigated who does this well. And I bought some of that equipment. So in this last, we just had this conference, Rocky Mountain Early Childhood Conference, and we had the refugee and immigrants from our programs. We also have a fatherhood program. It's one of the programs that are needed for maternal mental health. The women over and over said, and I know I'm digressing for a minute, but I don't want to forget to mention this. The women over and over said, you need to tell my husband. It can't just be me. You need to tell my husband, because a lot of pressure when you're a refugee and immigrant, the husbands or the fathers or the brothers are going through such immense identity crush, right? They've been in their own culture, they are seen as perhaps the family support, the this, the that. And when they come here to the US and you're a Black man from the Congo, you have no identity anymore as you did in your home country. What does that do to a husband, right? No wonder why domestic violence is increased and all those kinds of things. So we had to open up a fatherhood project as well. So that was on the side, but I wanted you to know that that's one of the wraparound services for maternal health, is that co-parenting, that co-regulation with the person that you're working with. Key. So back to the language. So in this last conference, so we had interpretation for the English speakers. So they're the ones who are actually wearing the devices so that people are presenting in their first languages. And then we hire people who are simultaneously bilingual and speaking to the English, right? That's the power. That's a start. I don't even know where it's going to go. So I'm teaching university professors. I'm also a professor, but it's my side job. I only teach 6 classes a semester, but I'm willing to use interpretation. And I have classes with 5 different languages in it. It is so exciting as a professor because Zoom makes that happen. But I actually did it in person as well because we have the system and the interpreters. And I found a college who was willing to invest in it. When you talk about what are the barriers, one, it's fear. You know, we got the dominant, we're pushing against the dominant. 2, economics is the push, right? It's one of the biggest barriers of all equity is economics. Where do we put our funding? When you write a grant, do you have interpretation? Do you have equipment? I mean, most of us don't even think about it. So if we really want to make equity happen, we have to think about heart languages because that maternal health is not going to take place until they can use their heart language to express what their lived experience is. So those are some ways we do it. And we get the state. We got the state 3 times to invest in translating materials. Yes, they have spent $45,000 in 2 years on our programs to translate materials. They've never done it before. When I'm a professor, as a professor, I'm going to Canada and Australia to find information in the languages I need. We don't even have a repository in this country to get languages unless it's on health. I can find 35 languages on COVID and how to prevent it. And I'm not minimizing the importance of that. However, if we're talking maternal health, we need to know about child development. We need to know about postpartum blues. Almost every woman out of the 92 that I've been working with on that first year never even heard of postpartum blues. They thought they were going crazy and were afraid to tell anybody because they were afraid their children would be taken away. So here they are at home, hormonally changing, crying, not knowing what to do, and they're afraid their baby's going to be taken away. You know, just to hear that story took me 6 to 8 months. So, and like I said, this is only a 2-year program right now. And I think we're going to get funding with these other, the stimulus money coming. So in 2 years, I'll let you know, hopefully more things that I'm learning and are failing forward and our successes. We haven't found another community. We found one in Minnesota that's doing similar kinds of things. We find a few colleges who are focused on getting women of color in and refugees and immigrants, but we really haven't found a holistic state-supported program. So we don't really have a model to follow. All I'm using are what I learned in the refugee camps and in other countries. And sometimes I think the global world is actually way ahead of us in programming. They just don't have the countries and the funding to follow it. It's like we don't sign on the Convention of the Rights of the Children and 192 other countries did. Doesn't mean they're following it, right? Just because they signed on it. But we know if we signed on it, we wouldn't be bringing our 10-year-olds to adult crime, because that would be illegal if we signed on it.
Wonderful that you've been able to create a model. If there was not one exists, it does now. So thank you for sharing. I don't want to monopolize, but if I missed it, could you share the name of the translation program that you invested in?
Yeah, that would take me a minute to go find it, but I give you my email here. Okay. And please write me and just let me know, and I'll share all the information. Of course, it's costly, but I have like little microphones so people can sit together and speak, and then have interpreters, and it's really fun.
Thank you so much.
Yeah.
Since we still have a few minutes left, do you think it would be helpful to have people do an introduction or to
Sure. That would be lovely.
in the audience?
I'd love to know who's on.
I'll go ahead and start. I'm Britt Newton. I was just the host of this breakout session, but I am on the board of 2020 Mom, and I am always learning, and I'm so proud of the work that everyone does, and thank you all for attending this event.
Should we go alphabetical?
I wish I can just kind of call out the names of people that I see, because it's kind of, and I think in a different order for everybody. Hoda, I think you just gave an introduction, but I think not everyone was quite dialed in. So maybe if you want to go ahead, since you're next on the screen.
And if you could say one thing that you're bringing from this presentation to tomorrow.
Great, thank you. So I'm Huda Shauki. I am a pediatric nurse practitioner, lactation consultant, but since doing that work, I'm now consulting in maternal child health for our first 5 in Orange County, California, and focused on perinatal mental health. And have been, so the thing that I'm taking away is exactly what you mentioned about the father engagement component, is that I'm trying to shift the frame to early relational health and not just maternal mental health, because it's all the relationships that impact the well-being of the mom and the baby, and hence the rest of the family. So I really love the way you framed father engagement, because just been trying to connect that to my work and have people understand the value, and you said it. So thank you so much.
Thank you.
Sherry, you're next on my screen.
Hi, everyone, and thank you, Deborah. This was wonderful. My name's Cherry Pruitt, and I work for HRSA's Maternal and Child Health Bureau. I'm the Region 8 Maternal and Child Health Consultant, and Montana is one of the states that has a mom's grant, which brings me here. But I will also add that I live in Lafayette, so I think, Deborah, you and I might be neighbors, and I'm on the board of directors for the Empowerment Through Education Foundation, which works to take South Sudanese girls out of refugee camps in Uganda and send them to boarding schools. So I might absolutely connect with you on just that kind of personal, your work sounds fantastic. So, and then in terms of work as the MCH consultant for the region, we have a lot of refugees, new immigrant, new American programs that many of our states are working on. So I'm excited to share a summary of your work with the folks, especially in Dakota.
Let's meet for tea at the Brewing Market on Arapahoe and 95th.
Oh, that sounds wonderful. I will take you up on that. I'll connect with you.
Perfect.
I love
Thank
it.
you.
Rebecca, you're next on my screen.
I'm Rebecca. I work with Catholic Charities in Denver, Colorado, and Catholic Charities requires all home visitors. By the way, I'm a home visitor with prenatal clients. They require all of us to be fluent in Spanish. So I would say about half of my clients are immigrants. Some of them are refugees. And so I know that they have unique needs compared to other clients of mine. And what was the other question I'm supposed to address?
I think that's it.
Well, what were you doing? What were you going to bring? What did you learn that you would incorporate? Sorry for the voice.
I'm sorry, can you repeat the question?
Yes, what would you bring forward tomorrow from today's time together?
Well, I just want to share, I'm multitasking today. I'm delivering groceries to my clients. I do it once a month. So I'm trying to think about this morning. I thought the speaker who was talking about the microbiologic implications of stress and how that affects pregnancy, I thought that was really fascinating. And also, you know, she talked about the effect on male babies.
Mm-hmm.
I want to explore that further. I'm not sure what else to add to that, other than that's probably the largest thing that I learned today. Unfortunately, I was with the client when the session started. So whatever you discussed earlier in the session, I'm sorry, I would go back and hear it in a recording.
That's great. Thank you.
Yeah, you're welcome.
Avery, you're next on my screen.
Hi, I'm Avery Effner. I work in Peoria, Illinois through the Children's Home Association and their Good Beginnings program. I have I'm through McV, and we just actually went through our accreditation process. So, and we have one of the things, we went through our grading scale, and one of the things was talking about is that we don't have the materials for the people, we just have English speaking materials. And that was something that I thought was kind of interesting, and making sure that they don't sit in the back that's kind of, we've pushed, I have someone in on my caseload that speaks Gujarati, and I do not speak Gujarati. I speak English. So, and then the other part was when you talked about making sure that they know that they have the power, and like you go in with humility and talking to them and like letting them know that they're the expert and like giving them the power to explain what's going on. Like that really struck a chord with me, because that's what I try to do with my participant that is that way, that is a different culture than I am. So, and then taking like this section back to like my my location and talking to them about like how important it is that yes, we've got stuff in Spanish, we have stuff in English, but we've got other things that we really should be looking at too in the future. Even though the population is small, it's still valid.
Absolutely. Thank you. And wouldn't it be nice to have a repository at the national level where all the states are contributing what they've translated, so we don't all have to spend the same funding on getting this stuff done?
Yep.
Write your senators, please, and your reps.
Thank you. Sim?
Hi, everyone. So my name is Sim. I'm actually in Australia at the moment. So it's about, what time is it? 5 a.m. here. So I'm just logging on, and I missed the presentation. And I'm originally from Berkeley, California, and I'm very interested in this particular topic. My background is in accounting and finance. I had my daughter in February of 2020, and that's when I became very interested in mental health in general, and obviously specifically maternal mental health, my own, and learned a lot about it, and taking it back all the way to my own mother, who was an immigrant from India, and had my brother, my older brother, right when she had arrived, and had a very isolating and lonely experience, and didn't know how to speak English, and spoke only Punjabi, and didn't have any resources, and was an arranged marriage, and didn't know my dad, and it was a very sort of challenging situation. So I'm looking at hoping to support organizations and offer my services, or just learn more, and I'm just very interested in this topic. Also on the board of Hand in Hand Parenting, which is an organization that supports parents with tools and support groups and things like that, and they have a method that's becoming evidence-based at the moment. So really trying to bring in different components of sort of culturally responsive care. So I will definitely listen to this recording.
Thank you.
Thank you.
Alejandra? I know people maybe have other things they're trying to accomplish too. So Stephanie?
Hi, I'm Stephanie. I'm with Perinatal Support Washington, and I am a parent resilience specialist. So that is peer support, and I do peer support for the Latinx and Spanish speaking community. And I am providing culturally matched care. So I am from the Latinx community. I'm an immigrant myself. And I just have to say it's so validating to hear your perspective from an organization and seeing the effort being made. I think that if anything, like when I talk to my participants and meet with them and have sessions with them, the thing that I hear the most is that it is so great to hear from someone within our community, from someone within our culture who understands, the medical setting and how daunting it can be to navigate these systems as an immigrant, and not knowing the language. Just it goes above and beyond of just the simple language, but also, these things, mental health is such a new thing, and it's still so stigmatized within our community that it is hard to talk to outsiders. It is hard to talk to someone who doesn't look like us, who doesn't understand our family dynamic sometimes. So I really just appreciate what you're doing out there. And I think that it is really great work and should be implemented in a lot more organizations.
Alexis?
Hi, my name is Alexis, and I am a legislative counsel for the American Medical Association. My portfolio covers maternal mortality and immigration, so I thought this was a good intersection for that. I don't work hands-on with the population, right? I just am at like the higher policy level doing, some of the comment letters and legislative review and things like that. So it was definitely interesting to hear, some of the more ground level experiences that I, at some points might pull on from other people, but I don't really get to experience, face to face. So yeah, just remembering to keep that sort of centered in what I do. It kind of makes me wish I was on the ground more and not, behind a desk so much. But yeah, thanks.
But policy drives. Part of what our grant is we had to inform policy, and now all emails that go out from the state to moms and early childhood are more simple. They don't have these long emails with all this information in. They use bullet points, and they have a translator available. That's a step. It's a very small step, but it's a step to help accommodate and move forward. So policy is really, really important. So thanks for all your work.
Thank you.
Yeah.
I think that's everyone.
Thank you. And I just wanted to mention that, the work we've had around the world for 30 plus years really informed how we work here. If you think about, so I work on Lesbos in Greece and we have refugees from all over, right? And even in Afghanistan, we have the communities who are fighting each other as refugees in the same refugee camp. So they are forced to learn how to deal with this, right? How to deal with languages, because their number one is protection, child protection, unaccompanied minor protection, women protection. And I don't know if you all know, but that went up in flames last year, right? And the whole camp went up in flames. It was a camp for 3,000. We had over 18,000 refugees in it, and the whole thing burned down. And then we had to rebuild afterwards. The global world is so much ahead of us. I really strongly invite people to get on like UNICEF, early childhood maternal health, because they're trying programs that are out of the box because they have to deal with it every single day. Here, the dominant culture takes so much precedent that it's like the unseen. It's not made visible. And when you're in a refugee camp, it is visible all over, right? I'm one of 10 white people in the camp, right? And so it is visible, the cultural mixes and diversity and the equity imbalances. And I hold the power walking into those refugee camps, right? That's like so sad. So the global really does have a lot of information out there. I just really want to encourage people to join the UNICEF webinars and things like that, because I think their ideas can really help generate innovation in this country. And thank you everyone for coming. I appreciate it. Sorry about the voice. I woke up with a slight fever and no voice today, but it's not COVID.
We appreciate you powering through.
Thank you. And Deborah, I look forward to meeting in person and sharing.
Yes, you got my email. Will you email me, please? Okay.
Absolutely. I certainly will look forward to it.
Thank you so much. Bye, everyone.
Bye. Nice to meet you.
Yeah. So I don't know if there's follow-up or do we do anything? That's it.
I think that's it. I think we end the meeting and it's recorded and people can watch, I think, at a later point if they weren't able to get everything. But I learned so much. Thank you so much. And I hope you feel better.
Thank you so much. And thanks for support. Bye.
Take care. Bye-bye.